Welcome to the Air Medical Today podcast. My name is Edward Ero, and I am your host for episode 38 on April 22nd, 2021. This podcast is part of the Ero Podcast Network, podcasts that inform by focusing on both the news and the people behind the news. With each episode of Air Medical Today, we explore a specific area of the air medical industry and community through the use of interviews. You can find Air Medical Today on the web at airmedtoday.com and on Facebook, Twitter, and LinkedIn. The audio podcast is indexed on iTunes and the video version is on YouTube. For additional information about the guest on the podcast, I also provide background data on the Air Medical Today website. If you would like to become a sponsor and or leave feedback, please write to webmaster@airmedtoday.com or call 612-367-6052. Today, I'm interviewing Mr. Robert Tester, the Senior Director of the Life Force Air Medical Service of the Erlanger Health System in Chattanooga, Tennessee. Before we get to the interview, I want to go over some feedback from previous episodes and provide some general updates. As I announced before, Air Medical Today is also a video podcast now. As always, you can listen to the podcast and now watch it on the new Air Medical Today YouTube channel. The link to the channel is on the Air Medical Today website. If you have not listened to past podcasts, please take the time to do so. There's some great information on how many of the large air medical consortium programs operate, as well as how they are reacting and adapting to COVID-19, including handling the stress that has been caused for frontline staff. Please tune in to these informative and timeless podcasts. I would also like to thank the followers of Air Medical Today on Facebook, LinkedIn, and Twitter. To date, Air Medical Today has 28,270 likes or followers, and it is increasing every day. Thank you very much. It is my pleasure to welcome Robert Tester, the Senior Director of the Life Force Air Medical Service at Erlanger Health System, on the podcast today. Robbie has been with Life Force since 1998 when he started as a flight paramedic. He has held several positions in the program, including program manager, administrator, vice president, and now senior director at Erlanger. His current position includes not only Life Force, but system-wide emergency management and the Regional Operations Center. Along with being a paramedic, Robbie holds a Bachelor's of Science degree in Healthcare Administration from Georgia State College and a Master's in Business Administration from Western Governors University in Tennessee. He has been involved with a number of associations and committees and currently is a board member of the Association of Critical Care Transport. Welcome to the Air Medical Today podcast, Robbie. It's really great to have you here.
Thank you, Edward. It's my pleasure to be here.
Well, the first thing I want to do is congratulate you on your 2021 Leadership Award with the Tennessee Ambulance Association. I saw that in a newspaper article, because I check out all kinds of RSS feeds, and this is a great achievement. What specific things were you recognized for?
Well, first and foremost, I appreciate the acknowledgement. My team nominated me for the state award, and
nice.
We've been members of the association way before I ever became part of Life Force, and it was a combination of things. I believe when I read back the nomination, if you will, it had a lot to do with the things that we've accomplished this year with COVID. COVID response at Erlanger landed in the division of Life Force from an emergency management perspective. So a lot of it had to do with that. Just our years of service to the state of Tennessee through the years and our growth there and how we've supported them. My involvement with the state, I chair the State Air Ambulance Committee, which is a subset of the State Department of Health, and I've been the chair of that committee for 8 years. And I think it was just a culmination of things. I felt that it was an award won for the service, not necessarily for me specifically. Obviously, we've got a great team at Life Force and a great bunch of leaders. So I think it was just a culmination of things through the years.
Yeah, well, it's nice to be recognized for that. How big is the Tennessee Ambulance Association? Is that a
it's
all?
it's a statewide organization. I would want to say there's about 120 services across the state, and that is comprised of air and ground ambulance services, primarily ground, honestly.
Yes, right.
Because they're just a lot larger than the air ambulance services. But I'm guessing about 130, 140 services across the state are members.
Yeah. Is there a AIMS chapter in Tennessee too, or is that separate?
We do not have an AIMS chapter. We do have a very active state air ambulance committee, and it is comprised of all the licensed ambulance services, licensed air ambulance services across the state.
Yeah.
And we do have good participation there. We're able to work things that are beneficial to the air ambulance services in the state, working with the Department of Health, and allows us to accomplish the things that we need from regulatory licensure, equipment, the type of mission, things of that nature.
Well, in going down some of the awards here, I noticed also in 2020, you received the AIMS Excellence in Transport Leadership Award, which again, congratulations. That's a big achievement. And also Southeast Tennessee Red Cross Healthcare Heroes Award. So tell us about those and how, what things you were recognized for.
Well, again, I appreciate that. The AIMS Award, I was extremely honored and humbled by that award. Looking at the recipients that have received that through the years, I'm not sure how I was picked, but I'm very appreciative nonetheless. I looked at it from receiving it on behalf of the program. We've accomplished a lot in our almost 33 years of history, and it's been a very stable program. I was very fortunate to be the third program director in the program's history in 33 years. So I had really good mentors and leaders, and I have a great leadership team and over right around 100 clinicians. So we're able to really do some really nice things across the state to benefit our patients and support the health system as a whole. I think if looking at the nomination, which I wasn't aware of at the time, things were focused on our growth, our quality programs, our team composition, the requirements we have for our teams, the partnerships that we have with EMS. We have a large outreach education program that we go out and do a ton of free education for our first responders, EMS agencies, supporting hospitals, things of that nature. We focus a lot on leadership and leadership development at the program. And, we support the MTLI program and others that we try to bring up new leaders in to try to set a foundation for succession planning, in the future. And that's always been very beneficial, to us as we grow. We're fortunate enough to not have a tremendous amount of turnover at the program. And I attribute that to the foundation that was set way back in 1988 when the program started. So honored to receive the award, but again, I look at it as an award that is for the program, not necessarily for me. I'm fortunate enough to lead the organization, and but I do that on the shoulders of many people that make it easy for me to do that.
Sure, it takes a team, but it takes good leadership to receive that. Did you receive that virtually because of the COVID?
I did receive it virtually. Which we've been members, such as organizations you've been a part of for many years, way back when the ASBEAMS and that organization. So Life Force has been a legacy member, if you will, of AIMS for many years. So I attended AMTC for many years, and so it was a little bit disappointing not to do that in person this year. But with the pandemic, it just kind of is what it is. But I was still very fortunate to have received the award.
Yeah, but then talk about the Red Cross Heroes Award. What's that all about?
Yeah. So again, I've said this a couple times. The hospital the Erlanger Health System did nominate me for the Red Cross Award this year, and it was solely related to the leadership and I guess the path that was set forward with COVID-19. I was asked by the hospital's CEO when this first started to step in and serve as the incident commander for the health system's response for COVID. So I did have to step away from the program for about 6 months and solely focus on our response to the pandemic. And so while I have good leadership, I have great operations support, and the folks did a phenomenal job while I was kind of absent for a few months there. But it was solely about bringing the whole health system together to respond to this pandemic. The Erlanger Health System is a tertiary quaternary centered, level 1 trauma, pediatric, level 3-4 NICU. So we are the region safety net hospital. And so, it was looked upon us to shoulder the burden of a lot of the response to COVID. Like everyone else, it was a learning game. And it took many organizations coming together and leading the charge, from the health department to our other sister hospitals in Chattanooga and Hamilton County. So it was a 24-hour operation, really for 3 or 4 months, assuring that we're prepared and how we're responding to the surges and things of that nature. So again, I was nominated and very humbled to have received it, but I had a great team and still have a great team to this day related to COVID, from infectious disease physicians, respiratory therapists, just everyone, ancillary services, nursing in the hospital that really come together. And I've never seen better teamwork in my 20 plus years at Erlanger to respond to this. It really put emergency management out in the forefront when this happened.
Yeah, that's fantastic, Robbie. I mean, I didn't realize that you had taken off some time from directly managing the program to. So were you in charge of the incident response or disaster planning for the hospital system already?
Yes, emergency management has been reporting up through my areas for really about the past 4 years. It really came to head when we had some disasters here in the local area. We had the terrorist event where the shooter, unfortunately killed 5 servicemen here in Chattanooga, followed by some pretty significant weather events, tornadoes, et cetera. And we've had some IT failures, which can cripple a health system in a matter of seconds. So we've had multiple events over the last 3 or 4 years that really put emergency management on the forefront and just reemphasize the need and the importance of planning. And I have some great people in emergency management. My operations manager, Jerry McDonald, which started as a flight paramedic, leads that on a day-to-day basis. And he and all of us do a ton of planning. And we were doing that prior to COVID, which fortunately just rolled right into place when the pandemic started.
Yeah, that's great. I mean, it's a fantastic experience. When I was at Duke University, I also had the responsibility for the emergency management, and we put in the HICS or hikes, so people pronounce it different ways. Did you use that type of system?
We did. We've been users of the hospital incident command system for many years. And luckily, with our nursing counterparts at the facility, we do a lot of training on that. We require any of our AOCs that take call for the hospital on a weekly basis to have their ICS 100 through 800 training, because they may be the first person to be the incident commander until some of us arrive and we can get stable. So we put a lot of emphasis on training of our house supervisors, our administrators, even our chiefs, are required to take the training, and they take it very serious. And we do a lot of training throughout the year in our command center, and going to paper operations was a big deal for us when we had an IT failure about 2 years ago now. We had to put a lot of those training practices actually in use, for several days while we dealt with the situation.
Yeah, it's a great system to have in place, and you're right about the training. We at Duke, I had put it in. It was before 9/11. And we had put and trained it. And the biggest things that I think people had trouble with is the, CEO and stuff. Well, I'm always in charge. No, I said,
Right.
well,
Yeah.
yes, but you might not be here. You could be traveling.
Right.
Someone has to be trained to run the program. And that was a big shift in thinking. But boy, did that work for 9/11. And then, of course,
Sure.
after 9/11, then it became more of a requirement through JAGO, with the joint saying that you had to have some type of system in place. And we were just lucky to have that. But boy, it helped us really assess, and I'm sure like you with the IT and with COVID, really assess where the weaknesses are, what things that we need to look at.
It did. And, in an incident like this, especially, I think the pandemic really brought this to light that you may have these weather events that last 24 hours or 48 hours and maybe lasting a couple days, but you have to have a plan for a long period of time, like the pandemic. You can't have a single point of failure. One person can't be the person all the time.
Right.
When you do this. I know when the pandemic started, we ran our command center 24/7 for about 2 months, just dealing with the unknown. So we had to have multiple people trained in how to do this and how to respond. You brought up a great point related to the CEOs and those folks that are ultimately in charge. I think it was a great testament for Erlanger's leadership that the CEO, when this pandemic started, not because it was me, but put emergency management in charge. It would be easy to step out in front and go, I'm running the show here. But I think everyone realized that this is going to be a big thing, and we really need to lean on the people that are trained to do this and lead us in that direction that we need to go. And I've never seen a group like our C-suite respond favoritively in that regard, because they just said, you tell us what we need to do, what resources you need, how do we need to respond. We met nightly at 7:00 in the evening just to talk about the day and how we're planning for the next day. We did that for a couple months.
Excellent.
In our process, but it was nice to see, whether it was me or anyone else, step out there, use the training that we've all had through the years, and lead the organization in that way.
Yeah, and I think the other important thing I learned was that, oftentimes when there's an issue, everybody wants to be there at the same time. Yes. And you go, no, we're running this 24/7. I need you rested, and you come in, and we need to turn it over. And I'm sure you planned for that well.
We did. I think the planning certainly fell into place. It's like everything else. There were issues that we had to step to the right and adjust. And of course, you have big personalities when you talk about, executives and physicians, and not everyone can be in charge. And that took us a few days to kind of set the foundation there. Luckily, we had great leadership on the C-suite side. Our president CEO is a physician also. And so he was able to assist in the navigation of all of the different personalities that you encounter in something like this. And honestly, I was very impressed by our physicians as well, because they typically are in charge, and they typically, want to set the standard. But these men and women did a great job, and they fell in line, no disrespect intended by that. But they said, look, you tell us what we need to do and how we need to respond. And everybody just really came together, cross service lines, which I've not seen a lot in my history at Erlanger. I'll go to the tent and take care of patients if I'm an OB, or if I'm a, whatever specialty I have. They were willing to, roll their sleeves up and do whatever is needed.
How did that work across the system too? Because it wasn't just the main hospital, right?
Right. It took a lot of planning as things abruptly, and I'm sure like other areas of the country, things shut down immediately. It was kind of, we saw this on the horizon coming, but it was like overnight things just shut down, especially when the governor issued the shutdown order. So we had to adjust very quickly. We have 8 campuses. Some are, larger campuses. Some are critical access hospitals. So everything was a little bit different, how we had to plan and adjust. One thing that we did make a decision on early on was the policies and procedures that are put in place are across the health system. So we're not going to adjust based on different campuses. We had to tweak a little bit, don't get me wrong, but one thing we did was try to lead forward with a common message throughout our campuses, and that did help us a lot.
Yeah.
If you go back to the screening, we started off by taking temperatures and we were screening people, and that was a big undertaking across the system to have to screen. We've got almost 8,000 associates across the system, and that's a big deal that no one ever planned for.
Yeah.
So it did take a little bit of adjusting from time to time.
Well, what a great experience that is to have done that. And again, congratulations for your award.
Thank you. I appreciate that.
Well, let's get in. I want to talk about a little bit about your background and then Life Force. But you started out, you went to school to be a paramedic. Why did you choose that field?
It's very interesting. I originally in high school down in North Georgia wanted to be an athletic trainer. And I was a student trainer at the time when I was in high school. And honestly, the thing that changed my course to this day is we unfortunately had a 15-year-old student that dropped suddenly with a sudden cardiac arrest. And watching that unfold and even though I was a student trainer at the time and 15, 16 years old, I was the person to do it because we did not have full-time training staff. So, going through that resuscitation, seeing EMS play a part, unfortunately, did not have a favorable outcome. But honestly, that set the stage for me to this day. And I still say that. Still see some coaches in the community that I talk to regularly, because I think that incident, when you have a death of a young person, that changes your life forever. For me personally, that set my course. Now I've varied back and forth a little bit through the years as I've matured, but I originally was going to become an athletic trainer and went to college initially to do that. And then there was a time where they wanted the athletic trainers to become EMTs. And so I took that path in the summer and became an EMT and honestly got hooked, with EMS and kind of changed my course just a little bit to focus on EMS full time. And so I did a little more of my formal education while working EMS, became a paramedic. And honestly thought that's what I wanted to do is be a paramedic. I worked in the North Georgia system for a while. Like many paramedics across the country, I worked multiple jobs and with small ambulance services in North Georgia, and eventually, wound up in Atlanta with what became American Medical Response. And they served Cobb County, which is the city of Marietta, as well as a lot of the city of Atlanta, Fulton County. It was a big 911 operation. And so fortunate to kind of get my full-time start down in that area.
Yeah. So was the service, it was formed into AMR? Was it when they were merging?
Yeah, they were, if my memory serves me correctly, when I went to work for the service, it was called Caroline. And through multiple acquisitions, I think 2 acquisitions while I was there, became AMR.
Okay. So let's cover your education. I know you went back to school, and I know this kind of goes into your work experience too, but you got a bachelor's degree in health administration. What drove that?
Well, I had already, completed a lot of my undergraduate education prior to getting in EMS full time. And so I went back and really loved healthcare. I just really didn't know how long being a street paramedic, would last. That's a hard job that these men and women do every day. So I wanted to continue my education, not knowing where I was headed. I had been in the fire service since I was 14 years old. And I started off in an Explorer program in Dalton, Georgia. And
excellent.
And wasn't really sure what I wanted to do. But I loved leadership, and in the fire service, there's a big tradition of leadership and bringing up young people and setting a standard. And so I love that part of our business in leading and supervision. So I became a supervisor in Atlanta pretty quickly, and probably more quickly than I should have at my age, but I did get into leadership pretty early. At the same time, finishing my undergraduate in healthcare administration, not really knowing at that time what I wanted to do with it, but I wanted to have that there in the event that I needed in the future.
Yeah, that's great. And then you later went back with an MBA. degree too, right?
Finishing that, at this time, we'll be finished this year. So
Oh, okay.
I went back and started working on that, just not knowing as I get older, and where my career is going to take me, what I want to do. And there's a lot with healthcare that's changing. You're in it every day, but I was very interested in going, back into seeing what's changing and kind of what to be prepared for in the next chapter, whenever that occurs in my life.
Yeah. So, is there a specialty in healthcare through the MBA, or is
it is a master's in business administration with an emphasis in healthcare?
Healthcare? Yeah, excellent.
Yeah.
So when do you expect to have that completed?
I actually will be finished in June.
Excellent. Wow,
So
that's
just around the corner.
I don't know how you have the time for all this, Robbie. I mean, my gosh.
Fingers crossed.
Oh my gosh. You went to Erlanger, I believe, is that after you were with AMR? And let's talk about your experience. You first became a flight paramedic. Is that something that was a goal of yours all along?
I always had an interest. At that time, I went to work for at AMR, which became AMR in Atlanta, and was actually asked to come up to the North Georgia Chattanooga market to address some concerns that they were having up there. They were taking on the Erlanger Health System contract at that same time, and actually needed some leadership. So it was kind of back home for me in a way. So I came back up to the area, honestly, not intending to stay, but wound up staying. So I executed the agreement with Erlanger. We started becoming their provider, started to get into some 911 operations in Tennessee. And that lasted for about a year. And then lots of changes with AMR, and the hospital made the decision at that point to start their own owned and operated ambulance service. So I transitioned to a hospital employee, brought that service up, and ran that operation for about 2 years. And that was the point that Life Force had the first paramedic opening in 14 years. And it basically had no turnover in the program.
My gosh.
It was only a 2 aircraft operation at the time. And I was not married yet. And I said, if I'm going to do this, I need to do it now. This opportunity may not present itself again. So I threw my name in the hat and was lucky enough to be chosen for that team. And again, it was very tenured. It was at the hospital here in Chattanooga, the original base, and was just lucky enough to be chosen. And honestly, my time as a flight paramedic, I still tell my team today, was probably the best, 10 plus years of my life, was flying on the helicopter full time.
Yeah, that's great. I that makes sense about the turnover. I just remember, when we started the program at Fairfax Hospital, it was a Bell 412. And so there was a national affinity with you all. I remember getting together with folks at the Air Medical Transport conference, but wow, that says a lot about the program, with that little of turnover.
Yeah, very, from that perspective, we had, and I know you probably know Dan Norman that started the program, and he came from the military, started the University of Tennessee's program up in Knoxville, and we modeled our program after that. This is prior to me coming on the scene, if you will. And Danny came to Erlanger to set up a very similar program to that with Bell 412s, and just really knew what he wanted to do, and he had the board support. And Erlanger originally in 1987, their intention was to put a ground critical care ambulance in service. That was their intention, and wound up with a helicopter. So that's how they got into the business, if you will, of air medicine. And honestly, Dan Norman and that group of people really set a solid foundation for the program. And we're still reaping the benefits of what was seeded many years ago. Our board at Erlanger is heavily invested in the program and take pride and ownership in having such a tool to deploy into the region. A lot of these small rural communities, the only face of Erlanger they get is with a helicopter and the crews that come and get these patients. So very fortunate from that regard that the foundation was set by him and many of the others way back then.
Yeah, that's great to have. Let's talk about, you moved up several different positions before your senior director position. Talk about those and what you did.
Yeah, so I, as you mentioned, I flew as part of the flight crew as a paramedic for roughly 10 years. And again, we had very little turnover at that time. We only still had 2 aircraft and just was a pretty small, tight-knit group. Our clinical crew manager, Ms. Paula Stoltz, had been the crew manager for many, many years and had decided to step down and pursue other interests. And I was kind of encouraged by the team you need to go do this. We need someone from within to take this on. And so I did apply and was chosen as the clinical crew manager. I did that for several years, where I just oversaw the clinical operations of the flight program, and which moved into the program manager and then the program administrator, where I oversaw everything related to the program. After that, we started taking on some additional responsibilities, as most hospitals do. It was not just the Life Force program. We took on emergency management. We took on the transfer center.
Yes.
Because we had a flight operations center, we took on the transfer center. So
makes sense.
A lot of us were pulled in multiple directions, and I was kind of tasked to stay focused on the flight program. And Steve Strawn, one of our pilots that became a leader in our organization, he took the path of the transfer center and getting that kind of under control. And then, we kind of took separate paths at that point. Through multiple administration changes at Erlanger, all of that eventually wound up reporting, to me. And so I actually had the Life Force program, the transfer center and bed control center, emergency management, and business development reported to me for a period of time because the helicopter had such a solid outreach program that our CEO at the time wanted Life Force to take that on.
Wow.
So we had a great team of business development folks, and we married our outreach team with their business development team, and it was a great relationship. But like everything in healthcare changes, So I served as a vice president of operations for about 3 years, and then there was some structure changes. So when they redid everyone's title, I wound up as a senior director with a lot of those same departments.
Yeah, I was wondering because your titles, that makes much more sense now with what you're talking about, because there's more to it than just the Life Force program that you're over. Yeah.
And like anything in healthcare these days, you do more with less, and so we did have to tighten things up. It's like any hospital in America. The money just does not go as far as it used to. So you look at other opportunities and other places of importance and merge them together, and that's what we wound up doing. So.
Yeah, it's the transfer center. We did that at Duke too. So I think probably around the same time that you all did that. It makes a lot of sense.
It does.
Because you can cross-train staff. And do you have bed control under that too, or is that?
We do. So when we first took on that operation, it was in 2 different locations. So we had the flight operations center up on the parking deck where the Life Force complex was, and the bed control and transfer center was honestly in the basement of the hospital,
Yeah.
And really, we just did not talk well together. And as we started to change and evolve, and this was right after our partnership with Medtrans, we made a decision to make an operations center, because there are so many synergies between the transfer center and flight operations.
Absolutely.
And we just were not maximizing that at all. So we did embark on the plan to create an operations center, which is what we have today.
And I think having bed control, what capacity that you have.
Correct.
With the transfers. So who do you report to at Erlanger then?
I currently report to the chief operating officer.
To the COO of okay. So let's talk about Erlanger in general. What types of services and how many locations does Erlanger have?
So we have 7 campuses. We have the main university campus located in downtown Chattanooga, and it is your tertiary quaternary center. And like I said earlier, it does everything from level 1 trauma to level 4 NICU and everything in between. It's a teaching facility. We're connected with the University of Tennessee College of Medicine, and primarily our focus is resident fellowship education. So we don't do a lot of medical students, but we do a lot of residencies, and I think we have 14 different residencies across the system, and probably 6 or 7 on average fellowships that we do as well. So we have a big surgery program here for acute care. So we have about 13 new surgery residents a year. There's a cardiovascular, neuro, pediatrics, OB, oncology, just about most of your big service lines, we have either a residency or a fellowship in. And the other campuses across, we have some small campuses in Chattanooga as well. We have a community-based hospital that's about 70 beds, and it has an ED and a cath lab, and some of your lower acuity patients, go to that facility. Then we also have another small community-based facility in Chattanooga as well that serves a specific area of the county. Very small in nature, very niche service, if you will, some outpatient physician practices, things of this nature. And outside of Hamilton County, we have 2 critical access hospitals. One's up in Bledsoe County, which is about an hour and a half from Chattanooga, and over in Murphy, Andrews, North Carolina. We have another critical access hospital there. And then we have one freestanding ED over in a very rural community of Dunlap, Tennessee.
Wow. Yeah, big health system. You had mentioned, fellowships. Erlanger and the University of Tennessee College of Medicine formed the EMS fellowship program. I wanted to talk about that.
Yeah. So again, it's dating me now, but I think this was about 5 years ago. Dr. James Creel, which has now unfortunately passed away, he started the first emergency medicine fellowship at Erlanger. And about 3 years into that, he was a big EMS medical director, just had lots of different touch points across the state. And he's like, look, I want to bring an EMS fellowship here. There's no better sandbox than Chattanooga. And I'll explain why that is we have a ton of different access points. Obviously Life Force is a big one, for folks doing a fellowship. But we have rural EMS, suburban EMS, a big fire system, in Chattanooga that does a lot of USAR and confined space and all these different, different services related to EMS. In addition, we have just the geography around Chattanooga. We have a big cave and cliff team, high angle rope team, lots of different touch points for a fellow, to get involved in.
Yeah.
Search and rescue, et cetera. So Dr. Creel was very passionate that, number one, it'd be an area that folks would want to come for a year and do a fellowship, but then they would get a lot of touch points, So our involvement was really related to the helicopter. He wanted these folks to be involved with the air medical program. And so I was brought on as an assistant professor of that program to bring these individuals on. And we just were introduced to our 6th fellow that will start in July, just this week. And it's been a great opportunity for us, and I think for them. Our first fellow was Dr. Frank Tift, and the reason I mentioned him is he's still with the program today. And he went through the program, completed it, and then decided he wanted to live in Chattanooga, married a local paramedic, and now he still flies with us one day a week and is one of our assistant medical directors. So
wow.
That's been a great thing for EMS to have that physician level support out there. And for us, the fellow flies with us after their first couple months. Then they're on a rotation with us where they're flying at least one day a week and very involved in our QA process and administrative meetings and crew credentialing and things of that nature.
Yeah, that's great. I think the fellowship programs are very interesting. At LifeLink, we interfaced two of the hospital regions, and Hennepin County had fellows that would rotate through the program, got to know them. And I'd always take time to talk about the administrative side of things and how the program ran and so forth. So let's talk about LifeForce. So when did the program begin, and what type of aircraft did you first use?
So the program started in 1988, and again, I think from my looking back in the history of the program, it looked as if Erlanger was going to try to start a ground critical care ambulance service. Is what their intention was. And then I believe when you look at some of our colleagues in the state, University of Tennessee, Vanderbilt, several of the big university-based systems, everyone kind of went into the helicopter business, and that broadens your outreach, and your depth and breadth is larger. So they embarked on doing a helicopter instead. We still don't have a ground critical care service. Just wound up being the helicopter. So. That was the intent. We started off with the Bell 412, and I believe we watched other people in the industry. We watched what University of Tennessee did and others. There was a certain mission profile that Dan Norman wanted to achieve, and that was lots of lift capability, infrastructure that would turn into benefiting us later related to IFR. But he knew what he wanted to do right off the bat. So we went into Bell 412s in 1988. We quickly were doing double patient transports. That was right out of the gate, the way the aircraft were configured. We did about 20%, 30% at sometimes double patient transports, because there was not the plethora of air ambulances across the state that there are today. So it was not uncommon that we use that aircraft to max capacity. There were only 3 aircraft in the state at the time when we started, and it was us, Vanderbilt, and University of Tennessee, and then the Memphis, Tennessee program started not long after that. And we were all kind of starting within probably 5 or 6 years of each other. Then we started looking at where our patients are coming from, and then we put the first satellite base in the state of Tennessee in 1995 up in Sparta, Tennessee. And that's up on the upper Cumberland Plateau area. And they were, 2 to 3 hours from anywhere. It was, whether it was Chattanooga, Knoxville, or Nashville, they just, it was a long ambulance ride to get them to your big metropolitan areas, tertiary care, trauma centers, et cetera. So the hospital embarked on that adventure in 1995 and put another Bell 412 up there. On that Cumberland Plateau. And a lot of those patients came back to Chattanooga just because of ease of access. It was easier to drive to Chattanooga than Knoxville or Nashville. So it worked out for us.
Yeah. So how many bases do you have currently?
We have 6 currently. So we had looked at putting a base. This was after I started with the program in Georgia for many years. And that was just an underserved area. That a lot of patients, because where Chattanooga is, we get patients from Nashville or Georgia, Alabama, North Carolina, and Tennessee. So we started a base down in Calhoun, Georgia in 2005. And that was the 3rd base that was actually an Erlanger base prior to our partnership with Medtrans. After that, we established a base over in Blue Ridge, Georgia, another very rural, underserved community. And then at that point, we ran into kind of what I call a fork in the road in the program, to whereas we needed to continue to grow, but we needed to place our aircraft differently. So we wound up putting an aircraft in Winchester, Tennessee, which is to the west of Chattanooga, going toward Memphis. But when we did that, we said, it's time to move the aircraft off the hospital, and put it out in the community. Yeah. So simultaneously, we opened a base in Winchester, Tennessee, moved our base in Chattanooga to Cleveland, Tennessee. And we operated that way for about 3 years. And then Erlanger was in the process of acquiring a hospital over in Murphy, North Carolina. And at that time, there was not really a lot of air medical coverage over in that Murphy, North Carolina area, so in that kind of western three of the state, and very rural in nature. At the time, the CEO said, "Look, we want to help these folks out with their hospital. We also want an aircraft over there." So we did put our 6th aircraft in Murphy, North Carolina, I believe in late 2018.
Oh, so you have to deal with a lot of different licensure and state requirements. That must be.
We do.
I'm counting 3 states. Is that right?
Yes, it is. And luckily, we have our quality assurance person is also our standards person. So he has a big responsibility making sure that we meet not only CAIMS accreditation, but all the state standards. Yeah. So we are licensed in Tennessee, obviously, but Georgia, North Carolina, and soon to be Alabama.
Wow.
So it is a huge undertaking.
It is. Is that difficult with your clinical staff, that you have to keep up their licensure in all the states if they move from base to base?
They do.
Wow.
And that's the unfortunate thing about this. The nursing compact has helped a little bit with this. The paramedic side of the house we struggle with because the replica really did not accomplish what we wanted it to accomplish.
Yeah.
So the paramedics do have to be licensed in all of the states. That some of the nurses do, and then some of them, if they're compact, it does carry over. But it is a constant upkeep with that because the scope of practice is different in the 3 different states, and so we have to adjust. And the scope of practice in the state of Georgia is different than the state of Tennessee. And, it's just a constant upkeep for that.
Yeah, I know with LifeLink, it was complicated enough dealing with a couple states, let alone 4 states. My gosh.
It certainly is a full-time job. There's no doubt about that.
So I know for the first 20 years, you had your own Part 135 certificate. Did the program start with a Part 135 certificate?
We did.
Wow.
It started that way, which that many years ago it was a little easier to do. The FAA was I won't say easier to work with, but there wasn't very many helicopter programs at that time, and so it was kind of chartering a new chapter for them. So that is the way it started with us. So we had the traditional, director of operations, director of maintenance, chief flight nurse, chief flight paramedic, those, kind of original structures of how things were. And we did that, like you said, about 21 years. And honestly, it's like many hospitals across America, the money just did not go as far as it used to. We were needing to grow and expand, and we're fighting for capital dollars within a big health system. And it really just came to a point that, our aging Bell 412s, while they were workhorses and they were fun to fly in, very expensive to maintain, and
Yes.
needed to be replaced. And from a, direct operating cost was just getting very, very challenging for a hospital. So we did operate our own certificate for that long, and then got to a point in the hospital's, point, if you will, financially, that we just had to do something different. So it started in 2000, probably started in 2007. Early 2007, we started looking at other models. We watched the University of Tennessee. We watched some other big academic hospitals go into a different type of model with either, a traditional vendor type model with an operator, or, this alternative delivery hybrid type model. And I honestly watched the University of Tennessee in Knoxville very closely for a couple of years as they did the same thing prior to us, and wound up, settling on and that's not intended negatively. We wound up settling on a hybrid type model with Metrians in 2008.
Yeah. And so what does the hybrid model, what does that mean? Because they all vary a little bit.
They do.
And what for Life Force, what does that mean? What services are MedTrans doing, and what is the hospital doing?
Well, great question. It was important even for our board, and they had a lot to do with the transition to a new model, because they did not want the service that had been around for so long to really change that much. Really just changing from an aviation perspective. So it was important for us to maintain that medical direction, our physicians, program leadership, the clinical crews. We did not want to give up our communication center. So we wanted all of those core pieces, business development, everything we wanted to stay with the hospital, because that's really where the brand was, and that's what everyone knew. So what we looked for was, someone that could operate the aircraft, provide new equipment related to aviation, new aircraft, et cetera. And then, provide the mechanics and the pilots, and they do help us with business development. So that kind of fit with us. They acquired our aviation assets, and then we've expanded since then. So everything outside of the aviation box, the pilots and the mechanics and the airframe is owned and operated by Erlanger.
Yeah, it's so the pilots you had, then they became employees of Medtrans.
They did. And it was kind of interesting because, you weren't real sure what to expect, to be honest with you. Any type of contractual process that you go through, you expect one thing, and that may not be what you get at the end of the day. But we were very fortunate from the standpoint that we had 100% of our pilots transition over, to Medtrans, and there was, they assumed their legacy benefits and their legacy pay, and kept everyone. So even though we expected maybe some turnover, we didn't see that. For probably the first year, everybody stayed exactly where they were. And we flew the Bell 412s for probably another year and maybe a half after the transition, while we had new aircraft in the pipeline, et cetera. So they stayed where they were for at least a year, which was very good to see.
Yes.
We didn't have a lot of our experienced people leave us. They stayed with us for a while.
And it's still helicopters, all Erlanger. Just now you had to add the operated by.
Operated by, right? Yeah, we the Life Force name. That's interesting from a history perspective. Back in 1988, they did a hospital naming contest to come up with the name of the helicopter, and one of our environmental services employees came up with the name, and that was the one that was picked, and so we trademarked that in 1988, and has been trademarked since then. And that's, will always, right now, it'll always stay part of Erlanger. So regardless of future relationships, the hospital maintains that name and the brand.
Yeah. So back to the partnership, are some programs have billing services done by the air operators or the partner, only because the hospital doesn't always, do a great job, or they, it gets mixed in with all the other billing. Yeah. Did you add that, or did billing stay with?
We did add that. And to your point, air medicine is pretty much a Part B service for the most part. And we, from an Erlanger perspective, that just was not their wheelhouse. Right. So we did outsource the billing component. We were very, just if I say, restrictive on billing practices, and have maintained that to this point. And honestly, since 2008, it's worked well. I mean, there's always little bumps in the road, even with, as contentious as the billing across the country is at this point. And I think that's one of the biggest issues facing our industry.
Yes.
Is, we haven't had those big issues. And I think it's the way we structured our agreement from the very beginning.
That's good. Took some foresight, because I know there's other programs that are gone into an ADM that have gotten into issues where there's, huge balance billing bills that people get.
I'm sorry. I think that's one of the biggest things that's dividing our industry right now is, if you get past this balance billing piece and surprise billing legislation, there's not a lot that separates, the industry at that point. That's just my personal opinion.
Yeah, I agree with you.
That's what I think.
Yeah. It's still, there's a lot of devil in the details with everything, but I think it was a good move, because there's no reason to be putting patients, they're dealing with enough, then all of a sudden to have some, humongous bill that they have to deal with. But the insurance companies have to come to the table on this too.
Oh, absolutely, absolutely. And Erlanger's, is a government hospital authority. So it's it's a governmental not-for-profit, and so that really puts us in a unique situation from that, because that's historically not what our type of hospital agrees with. So it's been a balancing act.
Yeah. I had read something too on the Regional Operations Center. Was that developed with MedTrans too?
We did develop that in partnership.
Yeah, so talk about that.
Yeah. So, and I think that's a great testament of what people can do together. I believe everybody at that time, and this was, if I'm not mistaken, in 2014 is when we did this. We did, our flight operations was up on the helipad, and our transfer center was in the bowels of the hospital. And, we came together and said, what are we missing here? And we sat down and said, look, if we could connect our transfer center bed control with the flight ops team, we're just really going to be communicating well. We're going to cross information. We're going to get helicopters dispatched to facilities quicker. We're going to capture more patients back to the system. And so at that point, we came together and said, let's do this. It'll be really one of the first ones for MedTrans. We modeled a lot of other programs that had done this across the country. We spent some time up with Carillion Clinic. Paul Davenport and his team up there were great hosts to us.
Yeah.
And we kind of used them and Mayo Clinic and Thomas Jefferson to kind of model what we wanted to do. And then we came together and did it. The hospital was very supportive. MedTrans was supportive. And the biggest challenge we had was finding the space to do it, at the hospital, because real estate's a premium anywhere these days in a hospital.
Yeah,
so
that seems pretty unique, working with MedTrans on that.
Mm-hmm. They certainly let us take the lead. They just, they said, look, we feel like there's benefit, to everyone involved here. And it was a critical point in Erlanger's history to where we may not have been the facility of choice for everybody, and so we were trying to change a lot of the image related to the hospital. We're trying to create that easy button for these outlying small facilities to send their patients. And so we moved into a just say yes culture, where we accepted any and all. Obviously we're adjusting from that now, but our job was to make the other people's job easier. And that's what we needed to do. So we embarked on the change, and our flight operations, they've been strong for many, many years and really needed no tweaking, but we wanted to model our transfer center and our bed control folks after what we had done with flight operations. And so we, it was a hodgepodge of staff in our transfer center. It was clerical staff, LPNs, RNs. And so we embarked on this critical care nursing model. So all of our staff that either staff the transfer center side or the bed control side are all critical care RNs. And the reason we did that was we don't do a lot of physician connection anymore. It's auto acceptance. So if it meets the criteria, they automatically accept on behalf of the physician. And so it cuts down the time and honestly gets people back to their patients at these outlying hospitals, but makes our process easier.
Oh, that's sounds great. Had you looked at other partners at the time with when you chose MedTrans? And
we did an very extensive RFP at that time, and we looked at everyone, and honestly looked at every model, because we were not convinced that we didn't want to do the traditional and just choose an operator to help us on, and then wind up settling where we are, and it actually has been good. It's not to say there's never bumps in the road, because I think there is with any relationship. But overall, I would say it's been a very positive thing for us since 2008.
Yeah, sounds like it's been a very successful partnership for you.
It has.
So, talk about your quality assurance and management program that you have at LifeForce.
That's one thing that I'm extremely proud of. That honestly, again, had a good foundation from the very beginning. We've had great interaction and support. It's a multidisciplinary team. We meet once a month and review charts, everything from pediatrics through adult patients, and we use a lot of the gamut metrics now. We submit to gamut. So we, like most services, I think we just did did the normal stuff for so many years, and we just weren't really pushing the envelope. And really over the past 4 years, we've really pushed the envelope on all the different metrics that we're looking at. In those meetings, again, we look at certain procedures that fall out. Of course, those are reviewed. We review every pediatric transport that we do with our pediatric medical directors. If there's an extended scene time and there's something abnormal based on delivery of the patient, if it gets flagged by trauma or neuroscience or something for air medical review, then we'll look at all those flights as well to see how we could have done things differently, better, or improved. Good physician involvement. I think that's key to any quality assurance program. We've got great medical directors. I can't emphasize that enough. We're very fortunate from that perspective, and they're very engaged in what we do and provide education. Being part of the University of Tennessee College of Medicine, we have access to a lot of subspecialty, physicians, which we take huge advantage of, from skills labs to simulation centers to all those different things that we can, remediate teams or bring on new technologies or therapies. It just allows us to do that much easier.
Yeah, that's great. Actually, talk about your medical director and how that works. And do you have other physicians that sit on a clinical council type thing, or you just access those specialists when you need them?
No, great question. We've been very fortunate at LifeForce. Thank goodness we've only had 3 medical directors in 33 years. So we started off with a surgeon, Dr. Riddenberry. He was the medical director for about a year when the program first started. And they recruited Dr. Don Barker, which at the time was the University of Kentucky, had started their flight program up there, or was a big part of starting the program there. And Dr. Barker was with us for almost 29 years as the medical director, and he retired, about 2 years ago now, and got out of clinical practice. He was a trauma acute care surgeon, very involved in EMS, was on the EMS board for many years, and just a great leader. In addition to being a physician. When Dr. Barker stepped down, we brought on Dr. Bob Maxwell, which is another acute care trauma surgeon, and he's leading our team at this point. But in addition to Dr. Maxwell, we've got Dr. Tiff, which was our original fellow. He has that emergency medicine side.
Yes.
So he's boarded in emergency medicine. He's boarded in EMS. So and also flies with us 1 day a week. So he's there. And then we recently brought on Dr. Yuv Kalra, which is a pediatric intensivist, and he is on board with us now about 6 months as an associate medical director for pediatrics. So that brings in the children's hospital component. So we're very fortunate to have those 3 gentlemen that are heavily and regularly involved in the program. But to your point, in addition to that, we do have a physician advisory council, which it brings on all the subspecialty physicians. So we've got great involvement from, Dr. We call her Dr. Sunny, but Dr. Sanananda is a high-risk OB perinatologist. So she works with us from a high-risk OB perspective. We have a neonatologist. We've got representation from our cardiovascular, cardiothoracic team, our neurosciences team, and we meet once a quarter with that group of folks to just assure that we're meeting everyone's needs. Is there new therapies, new medications, new processes that we need to put in place? And any time that we have a specific incident where we may have cardiovascular transport that didn't go appropriately, we can always reach out to those folks and get insight.
Does that group help develop and approve the protocols then in each of those areas?
I would say Dr. Tiff does a lot of the heavy lifting on establishment of those. And to our point earlier, they're all different based on the state. Unfortunately, we can have a general set that have to be adjusted by the state. But then he sends out like the cardiovascular stuff to our cardiovascular physician, OB to our OB, and they go through those and just make sure that everything is buttoned up. I's are dotted, T's are crossed, and any adjustments that need to be made, they certainly play a part in that.
Yeah. Well, so let's talk about your clinical crew. What is the crew configuration, and do you have specialty crew members that you bring on, like for neonate, or how does that work?
Yeah, so we our normal crew configuration, obviously pilot, but then we have flight nurse, and a flight paramedic. And that has been the team composition since the inception of the program. We did, from a standards perspective, we require all of our nurses and paramedics to have a board certification. So all of our nurses within a year have to be a CFR, and all of our paramedics within a year have to be FPC. And we require a ton of required annual education. So these folks, they can't be slackers and work here. They have to stay very proficient and sharpen their skills, or unfortunately, they can't be part of this team. So we hold a lot of folks to high standards in just our normal team composition. And we do everything with this team, with the exception of neonatal transports. When we do neonatal transports, we do bring a specialty team with us. One of the original flight crew members will go with them, kind of as a safety officer and another set of hands. And they do provide some clinical care as well. But we'll bring either a neonatal nurse practitioner and a respiratory therapist, or sometimes a nurse and a respiratory therapist.
Now, do they participate in the training too?
They do.
Yeah.
From a clinical perspective, they do most of their training there. We do train with them regularly related to the aircraft.
Yes, right.
The safety stuff.
Yeah.
They do a lot of our annual credentialing, though, night vision goggles, stuff like that. That's required by the certificate. But then we do a lot of team training too, how to work together. And I think it brings a huge appreciation of skill sets. Because the neonatal population is just really different. And, it's one of these, if you don't do it all the time, it's hard to maintain that skills proficiency. So I think there's a large respect for them toward us, as well as us toward them, and what they do. And it works well.
And then does the neonatal team, would they get on any one of the helicopters, or is it just a couple bases that are doing that?
Well, we do. Any and all of the EC-135s are subject to be pulled for neonatal transport. I would say the majority of the time we're either using a Cleveland, Tennessee base, because it's only about 11 minutes from the hospital.
It's close, yeah.
Or Winchester, which is about 16 minutes, from the hospital, give or take. Those are the two that do the majority of those transports. But again, if we have our EC-135 from Murphy that's on the helipad when a NICU transport is dispatched, then they're subject to go as well.
Right. And the neonatal, I think that what their standard is 30-minute liftoff.
30 minutes.
Yeah.
And really, we try to do better than that. Sometimes the weak link there for us is getting the team up there, getting them away from the bedside, getting their gear. Usually by the time they get to the helipad, the helicopter's there and ready to go. So, but our goal is 30 minutes or less.
Yeah. What, on the programs is CAMES accredited, right? How long have you been CAMES? And
we, if I'm not mistaken, we became accredited in 2008. If I'm not mistaken, somewhere right around there, and have maintained. We've been through 3 reaccreditations since then. I think that's right, 3 or 4. It all becomes a blur
right.
after that point. But
it comes around much quicker than you.
It sure does. It sure does. And we did that for a multitude of different reasons. Number one is really taking a deep dive look at ourselves to see, you always think you're better than you are. And that's my opinion. And I think folks like that allow you to pull back the onion just a little bit, see what, where you could potentially improve. I feel like it did clean up a lot of our policy processes, redundancies in policy, and really held us accountable to our quality assurance processes.
Yeah. Talk about your safety program too. How does that operate?
Again, very fortunate from that regard, and to give an acknowledgement, our safety chairman, Robert Berger, is one of our flight paramedics up in Sparta. He won the AIMS Safety Award the same year that I won the Leadership Award.
Yeah.
And Robert, he's a paramedic. He's also a private pilot by trade, but he's chaired our safety committee for about 9 years now. And it's a multidisciplinary committee that involves not only the clinical staff, but aviation maintenance, Med-Trans's safety department and their safety management system. It all integrates together, but he chairs that and runs a very tight ship. They look at everything from recent and relevant industry events and how we can learn from that.
Yes.
We review anything that's happened within the program. And we have great participation. Every base has a site safety officer that may be a pilot, nurse, or paramedic. It just depends on who it is. In addition to maintenance representation, aviation representation, and again, MedTrans's overall safety, either director or regional person is always there.
Yeah. How often does the safety committee meet?
We meet once a month,
Yeah.
and right now, it's virtual, like many things
Yeah.
are. But again, we cover a host of different things. MedTrans uses the Baldwin system for reporting.
Sure.
So everybody has access from the communication center through the pilot has access to that system. We all have visualization on it and can respond and adjust and, acknowledge whether it's NOTAMs or an incident that did happen. We all have eyes on it. And it works very well. A lot of folks use pilots, and they would be your most obvious choice, from a safety committee perspective. But Robert has just done a phenomenal job, and again was recognized this year for his safety efforts with the team, and couldn't be prouder of him.
Yeah, that's great. Yeah, because safety is really much more all encompassing, and I think it has grown from just looking at it from an aviation perspective. Was MedTrans able to add more to the look at safety than when you just had it as a program level?
I think it has evolved. I think we did things extremely safe back then. I think, however, when you're only looking at yourself and no one else has eyes on you, I can see where you could be a little more complacent than other times. I think, being multidisciplinary now with folks that see other programs in the industry, they may pick up on things that we're missing, so I think it's been a good system for us just to hear what other folks are doing in the industry, what other bases, incidents that do happen. You have a failure of a stretcher in one market that transitions over to us for us to look at the same thing and maybe not have that same mistake happen in our program. So I think it has been very beneficial for us.
Yeah, I know in the programs I've been at, we've always reviewed the concern network stuff, but not as many people are really posting to that anymore. It's harder to get information.
It is now. Robert, he and others even go further than that. They're looking at the FAA stuff. They're looking at the NTSB things that come out. Unfortunately, our industry's had some bad outcomes, and when that unfortunately does happen, we've taken each one of those and looked at it and to see how we could do better or be more aware of things that happened and how we can improve from that.
Yeah. Let's see. I was real interested. You had a critical care rapid response vehicle, and I know other programs that have looked at that. Talk about that and how that started.
Well, honestly, it started probably 8 or 9 years ago. And I can tell you why it started. It was an interesting thing. Our aircraft can't fly in all conditions, as we all know. There are certain weather things, lightning, ice. The Tennessee Valley is, you can't do a lot of IFR. In the wintertime, we do a lot, but, as the cloud layer lowers, you've got icing conditions. So we had several situations happen where we had just critical patients out in the region and just had no way to get to them. The local ambulance services obviously play a huge role, but and some of them even have started doing critical care ground transport, but it was missing that critical care component of bringing the equipment and the blood and the plasma and all the stuff that we bring on board the aircraft. A lot of these services were missing that. So we looked at it and said, well, how can we accomplish this without, number one, getting in the ambulance business? That's not always popular. Folks think you're trying to steal their business, or how can we do this that's not polarizing or competitive or things of this nature? So we embarked on the SUV concept, almost like a paramedic intercept service that other parts of the country does. I did have the fortune of leading that charge. I went to our hospital auxiliary, which is our volunteers, and said, look, here's what I would like to do, and here's why. And I gave them several examples of, we had a hemorrhaging female postpartum that needed blood products, and we had a kid over in North Carolina that needed critical care, and presented them with multiple issues that we had, and they're like, go do it now. So luckily they provided us a grant. At that point we had 4 bases, and we went and bought 4 SUVs, and they were wrapped up to look like the helicopter. And the purpose of that was, when we're down for heavy maintenance, or we're down for weather, or we're down for whatever reason and can't fly, that team is still available to respond. So they'll go to an interfacility transport, help EMS move the patient, provide that critical care level of service. They'll go out and meet with EMS if they got a big entrapment or something, and they're needing some specialized services. We can respond out and do that. We had an incident, just 2 weeks ago, where we had 2 very sick children in North Georgia at a small hospital, and we deployed 2 bases, critical care vehicles down there for those 2 patients, just because they were strapped on resources, and they just didn't have enough people to take care of them. It's been a great service. We don't bill for it.
I was just going to ask you that.
Yeah, there's not a mechanism to do that.
Yeah.
But it's just the right thing to do.
So does that crew then get on the ambulance?
They do.
Then, yeah.
Yeah. Whoever the local service is, we work with them. They'll do a risk assessment when they get there with the crew. And, if it's in the middle of the night, they'll talk about, how long have you been up, and, safety of the vehicle and things of this nature. And then they'll do the transport with that EMS crew back to the hospital.
Yeah. I think one of the hard things too, you mentioned billing, and I was going to ask you about that, and that's difficult. But the other thing is, weather sometimes, it changes, and then you get involved with these, and you have to do what's right for the patient, obviously, but you could be out of service at that base for hours and hours where you could have gotten back in service. So
yeah, and honestly, that's a balancing act, and we do it all the time. What we do to try to mitigate some of that is, if it is a passing weather system, then we'll have the pilot and aircraft meet the crew at the hospital and pick them up. We do that as much as we can. Sometimes we can't, and they'll go back to their service area background and then get back in service eventually. But we try to, it's a constant moving target for us on that, unfortunately. But again, I look at it, if it were my child, in one of these outlying emergency departments with limited services, I would certainly want to do that.
Yep. I've got a few more questions. One I always like to ask, because I think, as you know, from MTLI, and I know you're an MTLI grad, and is strategic planning. So how does Life Force do their strategic planning, and is that part of the general hospital strategic plan, or do you have a separate plan for the program?
We have both, honestly.
Yep.
We do part of the system as a department of the hospital. We do our plan that focuses on our impact to the health system. One of the statistical numbers reported to the board every month is helicopter transports. They like to see how we're doing, and what patients we're bringing, and visiting aircraft and things of this nature. So it does play a big role for the hospital in general. We look at how we can impact the hospital from a market share perspective, patient flow perspective, those downstream benefits, if you will, to having the helicopter program. We work very closely with business development. So when we look at, market share and branding, the helicopter program plays a big part in that. And when we go into the region, and so it does play a big part of their strategic planning. Internally, we do the same thing, just as a microscopic view of the flight program. What we're doing, what we want to accomplish. Is there potential growth? Is there, we've never relocated a base, but we always look at it to make sure we're still doing the right thing for the communities that we serve. And is there opportunities out there for us? We do submit for capital. Everything has to be tied into the strategic plan within the health system. So if we're needing, new monitors, new ventilators, ultrasounds, whatever, we have to, be part of that strategic process, to potentially get that funding needed. But we do that annually, and it's a multidisciplinary Not just Erlanger. We do involve MedTrans with that. We're part of their strategic process, as they're going into year after year, and where do we fit into that? So multiple levels there.
That's great. That's the way to do it.
It is,
because you have to, and it has to become part of your normal operations too. I've known programs that, it was actually a hospital. You get a strategic plan and you put it up on the shelf, and no one's allowed to see it. And so, how are we supposed to implement that? So,
that's right.
So, we touched on COVID and all the work that you've done. How specifically did it impact the program, initially and then ongoing?
Yeah. So, it was like everything else. It kind of really came to a stop, for really about 30 days there when folks just started staying home. They weren't going to the hospital. People weren't on the roads. Your domestic level stuff really, it just all dried up, for the lack of a better word. And for about 30 days, we just didn't fly a lot of patients. And I think that's where a lot of folks, folks were not coming to the emergency rooms. So everybody's volume just kind of tanked off with the unknown. And that's really prior to all the infection starting. So we were kind of figuring out what do we need to do here? And I think even our team and I talked multiple days in a row, like, okay, what do we need to adjust? Do we need to, do we need to close the base, for a period, what do we need to do with staffing, all these different things. And it impacted us for about 30 days there, where we basically didn't fly a lot of patients. I mean, very few at all. We made the decision early on to stay the course. We did not shut down any bases or reduce staffing or any of those things, just because of the unknown. We didn't know. And so we all just kind of rode out the unknown, if you will, until we kind of started to see things peak and get back to normal. So about
is that in like the March, April time period?
Yes. So about 45 days into it, it really started to pick back up, and folks started moving again, and you started seeing the infections, and, and that just started to spike, uncontrollably. And we had to adjust, not knowing, levels of protection. We started off in the N95s and the goggles and trying to protect everybody with shields. And then we wound up shifting over to the very similar to LifeLink, to the aviation respirated fit system, in there, so the crews could still do their job, but be protected, so we had to make some huge investments in that to protect the staff. Certain subsets of patients we couldn't fly initially, your CPAP and your BiPAP and those folks that were off-gassing, aerosolizing stuff, we couldn't fly those patients because we couldn't protect our staff and pilots. And, so it was a huge, change for us that I think we, like everyone else in the country, just had to adjust daily almost to doing it. We had, like other areas, while we put in very strict processes related to social distancing, masking, all these things, we did wind up with infections within the flight program, some on the job, some off the job in the community. And it did impact us there for about 6 weeks, where while we didn't, knock on wood, have to shut a base down, we did have to adjust staffing and bring people in, to make sure the bases were covered. It was a stressful time. We unfortunately, I'm sure you saw, we did lose a pilot during that process. Stu Bass, which was one of our pilots over in our Blue Ridge area for many years, contracted COVID on the job, and unfortunately succumbed to his process. But we just walked through it day by day. Honestly, it was a big blow to the program. But it also made, I think, everyone realize this is serious. This is a very serious business, and we need to pay attention. Even though you want to relax and you want to become even more complacent just because you're tired of it, the whole fatigue factor. This is serious stuff, and it doesn't have a specific body type or age or underlying disease process. It just really, it's like Russian roulette. It's either your turn or it's not your turn.
Well, it takes, as I've always said, universal precautions. We're always supposed to do that, but this takes it to a much higher level, that people have to be cognizant about. And have your transports picked up with that you're actually transporting COVID patients that need ICU care from outlying facilities?
So we still do several a week. 4, 5, 6 a week that are COVID positive, needing that tertiary quaternary care. It's one of the things we just started implementing the hood concept, for BiPAP and CPAP, like some of the other air medical programs in the country, so we can fly those patients that are not necessarily intubated yet. We can fly those patients. So we're still seeing 4 or 5 a week that we have to, fly the patient, then we have to decontaminate the aircraft and those things. So it's certainly still there. It's not gone. We went from 140 in the hospital down to we're averaging about 20, 22 in the hospital right now. It does ebb and flow a little bit, but we're certainly not seeing the amount of virus that we were.
Yeah, it's interesting, different areas. I mean, Canada's getting hit really hard up in the Ontario area. Michigan is just, it's like in the early days when New York was hit and they didn't have ICU beds and needing all kinds of care. How's the vaccination program down there work? I mean,
with emergency management, we're a big part of leading that effort for the initial vaccines. And we have a employee population of probably about 8,000, 8 to 9,000, give or take. Some of those are subcontractors, but we led that campaign and probably vaccinated about 75% voluntarily when we did roll out the vaccine. And that went very well. We learned a lot pretty early about how to do that in masses. And we constantly had to adjust our strategy a little bit day by day to get everyone in. But what was so interesting about that, I tell people still to this day, is when we started doing vaccine, it's like, it didn't matter who you were. You could be the CEO, you could be a physician, you could be an environmental services worker. You all stood in line together. You all rolled up your sleeve and you got, there was no pecking order, if you will, for who got it first. And we did that purposefully. We have not mandated the vaccine here yet, just simply because it's still on emergency, authorization. I think we'll get there eventually, like we do with influenza. But right now we've not chosen, to do that.
Do you require flu shots?
We do require flu.
Yeah.
And I think we'll get there eventually. We just chose not to do that yet.
Yeah. Well, I always like to finish up. You seem very, very busy. I'm just amazed at all the things that you do. So I know you have a personal life too. You want to talk about your family and children?
Absolutely. Anytime. So I'm married to my wonderful wife, Rachel. Almost 15 years now. Rachel's in the aviation industry, aviation safety, and has an EMS background as well. Does a lot of the IFR infrastructure stuff across the country.
Interesting.
So been very fortunate to be.
Did you guys meet
her.
through work? Did you meet through?
We did.
Work?
We met through the Life Force program. Her mom has been a physician in Chattanooga for over 40 years, and so she was introduced as a young girl to the flight program, and then we met many years later after she went to college and came back, and so we did meet there.
That's a great story.
We've got two boys, a 9-year-old and a 5-year-old, both athletic and full of energy, and keep us on our toes. So we are very fortunate and blessed from that regard.
It sounds like they'll be supercharged with the two of you and the energy level that you guys have. So.
Yeah, they keep us on our toes. That's both are in sports and athletics, and it's a constant in our house.
So what, do you have other activities that you like to do, outside?
Yeah. So we, the family has a cabin not too far from here.
Oh, nice.
We spend a lot of time at, and we have a boat. Love to be on the water as much as we can during the summertime, and we love being out doing that. Big snow skiers. So we try to, and not been able to this last couple of years, but try to go snow skiing at least once a year because we don't get a lot of snow in Tennessee. So
I was going to say, where do you go skiing usually?
We try to go out west, but most of the time, whether Colorado, we went on the East Coast some, but we try to visit around Colorado. One of our big things is to go to Utah. We want to do that in the next, hopefully this year.
Oh, nice. Yeah,
experience things like that.
Is there any skiing in Tennessee?
No,
anywhere in the mountains.
We're very. There is a little town in the Smoky Mountains called Gatlinburg, and it's a very touristy. And there's a little ski hill there, literally with one lift, and it's like skiing on ice. But you can go up there and take that on if you'd like to.
Yeah, I know. When I was up in Virginia, Virginia has some skiing,
Yeah,
and then West Virginia, of course. But
Yep.
a little bit different than up here. And of course, we have skiing up in Minnesota, Wisconsin, but it tends this is more a hotbed for cross country skiing because it's a little flatter. You don't have the big mountains. So, well, is there anything else that you'd like to talk about before we close up?
The only thing I think I failed to mention, and again, this was prior to me in 1994 with the program. Erlanger was the world's first GPS approach into a hospital.
Yes.
And I meant to mention that earlier and just slipped my mind. And Dan Norman and his team at the time worked with the FAA, started the process for helicopters. There were helicopters doing IFR, but there was none doing really precision approaches into a fixed facility. So the Erlanger helipad, which we still use today, it was the world's first in doing a GPS into a fixed facility. And we've got about 21 of those across our service area that we still use, regularly.
That's amazing.
That was a big milestone for the program.
Yeah, that's I had the opportunity to put 5 of those in when I was up at Duke, but it's amazing. I know Mayo has done a lot with approaches too, and that is real important because it's nice, but if it's strictly IFR, then you're really just landing at the airport. Then you have to add in the ground transport when you can do the GPS approach. So,
and we still do a lot of it. I mean, it varies, with now the aircraft from a fuel perspective and alternate perspective. There's still some complexities out there that doesn't allow us to do it all the time, but it still provides us access to certain communities, and getting those patients back into the hospital versus the airport, I think, is huge. It gives the pilots another an option there.
Yeah. Thanks for mentioning that. I know we had talked about that earlier. So, well, Robbie, thanks so much for taking the time to be on the podcast. I know you're an extremely busy person, so I appreciate you doing that, and I look forward to
it's my pleasure. I appreciate you asking, and again, my pleasure to be on.
Yeah, and congratulations again for the awards.
Well, thank you very much. I do appreciate that.
Thanks for listening to this episode of the Air Medical Today podcast. Please come back again and also subscribe to future shows by visiting the website at airmedtoday.com, iTunes, or the Air Medical Today YouTube channel. Air Medical Today is also on Facebook, Twitter, and LinkedIn, and you can find the links on the website. Remember, if you would like to become a sponsor or provide feedback, please write to webmaster@airmedtoday.com or call 612-367-6052. Special thanks to Stanley Reeves of Room Tunes for providing his song, Track 5, for use as the theme song for the podcast. You can follow Stan on Facebook at facebook.com/stanley.reeves.39. Take care and fly safe.